Good evening, everyone. I am myself Dr. Gowthami, working as junior consultant and pediatric intensivist at Andhra Hospital, Vijayawada. So today, I would like to discuss an interesting CNS case. So we'll start the case-based discussion. Coming to the history, here is a 14-year-old male child with complaints of fever for 10 days, treated outside as enteric fever. And the same child had an episode of seizure, which is GTCS type, lasted for less than 10 minutes. So the referral pediatrician, loaded with anti-epileptic and once seizure subsided, referred the child to our hospital for further management. So on initial impression, child is appearance-wise irritable, peripheries were pale, and there is tachypnea. So what is the physiological status of this child and what intervention you want to do? Hello?
Unstable, life-threatening.
Yes, the child is in unstable life-threatening condition. So would like to start the child on oxygen and make things ready for your IV access. So here this is the primary assessment. So on primary assessment, airway is maintained, breathing, there is a tachypnea, rate is around 30 per minute, air entry equal, no added sounds, maintaining SATs at room height. Coming to circulation, there is a tachycardia with feeble peripheral pulses, cold peripheries, and there is hypotension. And coming to disability, child GCS is around 10 by 15, GRBS is normal, there is no fever. So what did you identify here? And how you want to, what intervention you want to do? What did you identify here?
Primary CNS dysfunction.
Yes, disability wise, there is primary CNS dysfunction. So airway. So here airway is maintained. So we will follow the same, evaluate, identify and intervene. So what I identified here is airway maintained, breathing almost normal except for some amount of tachypnea for which already we started child on oxygen, and circulation wise, I noticed the child is in hypotensive shock. Hypotensive shock. Next, disability wise, primary CNS dysfunction as we already told. So what intervention you want to do here? So airway breathing part already taken care. So now I would like to start child on fluid bolus for hypotensive shock, and also I would like to take neuroprotective measures. So here, this is what we did. So we secured an IV access, sent blood investigations, fluid bolus, and started child on NORAD infusion. And neuroprotective measures, given 3% NS bolus and started infusion. Child already loaded level outside, so we are continuing. And next, blood culture sent and given first dose of antibiotics. So on secondary assessment, there is a significant past medical history, and CNS examination wise, there is altered sensorium, we already know, and the tone is normal and DTR are exaggerated. Then outside investigations, the Whitehall titers showing TIVO 1 in 160, remaining titers are normal, and MRI brain is normal except for some evidence of cerebral edema.
Tablets.
Hello?
Meningitis.
Meningitis is one possible leading. Anything else?
Encephalitis.
Encephalitis. So here the child is treated outside as entry fever, and even significant titers are present. So first we kept the DD of enteric encephalitis and maybe other possible bacterial meningoencephalitis or viral encephalitis, or it could be CSVT also. What we want to do in this child? What workup you want to do in this child?
Lumbar puncture.
Directly lumbar puncture, or you want to do anything? So what are the contraindications to do LP here in this child?
Papillary.
At the time of presentation,
Rise racity.
child present in altered sensorium and also outside MRI showing some evidence of cerebral edema. So I don't want to directly go for LP in this child until I rule out cerebral edema. So what are the other investigations you want to send? So CBC, we send CBC, CRP and electrolytes.
Protein, CBC, CRP, electrolytes. We need to send.
Yes. So we see what are the reports. So there is an elevated total counts with neutrophil predominance. HP is normal. There is thrombocytopenia. CRP is 75. And we did CSF analysis the next day once jail sensorium is better and we think there is no cerebral edema. Like after we took care of all we took all anti-edema measures and child sensorium also better. So that time we did CSF analysis. It showed 40 cells with polymorph predominance and significant protein. We sent PCR, that is meningoencephalitis panel from CSF sample. It is negative. And we repeated Vidal test. It showed increase in titers. So what is the diagnosis here? And how you want to treat this child?
CSF analysis suggested of bacterial meningitis, no?
Yes. And there is a significant rise in titers in Vidal test. So possible it is a probable enteric encephalitis. And we sent blood culture which turned to be sterile after 3 days, like after 48 hours. And we continued antibiotics and started injection dexamethasone. So
Madam, what was the CSF cytology, like gram stain?
Gram stain negative, ma'am, and there are significant cells with polymorph predominance. So what is the antibiotic of choice in enteric fever?
Third
Third one.
Can you come again? Hello.
Third generation cephalosporin tetraid.
Third generation cephalosporins. Anything else? Okay. So this is a slide showing antibiotic of choice for typhoid fever. This is from Nelson. So it is again here it is divided into uncomplicated typhoid fever and severe typhoid fever. So in severe typhoid fever, in fluoroquinolone sensitive cases, we can start fluoroquinolone. In multidrug resistant children and quinolone resistant, we should start third generation cephalosporins, that is ceftriaxone, cefotaxime. So this child is already started on ceftriaxone outside. So outside ceftriaxone is given almost for 3 to 4 days. Then in view of further worsening, child is referred to our hospital. So in this scenario, what is the drug of choice in this child? The child is already on ceftriaxone, adequate dose. After 3 to 4 days, there is a clinical worsening and even there is a significant increase of titers. So what is the drug of choice here?
Chlorochloroquine.
So there is already ceftriaxone will be given in multi-drug resistant or quinolone resistant cases. And if there is a resistance to ceftriaxone, the next drug of choice will be azithromycin. And see, azithromycin is the drug of the choice in ceftriaxone resistant. Ceftriaxone resistant children and ceftriaxone resistant isolates. And if the child is hemodynamically unstable or the disease is severe, then meropenem may be used. So in this child, we started meropenem and azithromycin. And this reference is from IAP, Standard Treatment Guidelines. So, and after starting meropenem and azithromycin, there is a clinical response. So what are the indications for steroids in enteric fever? Anyone to answer this question?
Very severe disease and I think involvement of GI system and complications of meningitis.
Yes, ma'am. Yes, ma'am, exactly. If steroids are indicated in severe form of disease, when child presents in shock or coma or in altered sensorium, the recommended dose of dexamethasone in enteric encephalitis or severe enteric fever is 3 mg per kg initial dose, followed by 1 mg per kg every 6th hourly for 2 days. And this difference is from again IAP guidelines, standard treatment protocols. So we started child on dexamethasone and we gave for 48 hours. So after changing the antibiotic to meropenem and azithromycin and starting the child on dexamethasone, child sensorium improved, platelet counts increased, and we could discharge the child home after 14 days of IV antibiotics. And at the time of discharge, the child is had normal sensorium, able to walk. So after 4 days, child presented to ER with complaints of fever for 2 days, vomiting for 2 days, and altered sensorium for 1 day. So on primary assessment, airway is maintained, breathing, there is mild tachypnea, and circulation wise, there are bounding pulses and BP corresponding to 5th percentile, and there is some tachycardia. And coming to disability, GCS is 10/15, and there is child is febrile. So what did you identify here? What did you identify here? Anyone? Hello? Hello, am I audible? Hello? Hello, am I audible?
Yes, ma'am.
Okay. What did you identify here? So evaluate, identify, intervene. So what I identified, airway is maintained, breathing is normal except for some tachypnea. Child is in compensated shock and it looked with bonding pulses and wide pulse pressure. So it is distributive shock. And there is primary CNS dysfunction. How do you want to intervene here? So child is in compensated shock and it is distributive shock. So I directly started child on noradrenaline infusion and also started neuroprotective measures. So secured IV access, sent blood investigations, started noradrenaline infusion and started neuroprotective measures like 3% NS bolus and infusion. And we converted his oral anti-epileptic to IV maintenance dose. So on secondary assessment, there is hypertonia and we couldn't assess power because child sensorium is subnormal and there are absent superficial reflexes and exaggerated deep tendon reflexes and plantaris extensor. After taking neuroprotective measures, child sensorium started improving and power could be assessed and it is around 3/5 in all 4 limbs. So there is hypertonia, decreased power, absent reflexes, exaggerated DTR and plantaris extensor. So what signs are these?
UMN lesion.
Yes. It suggests that it is UML lesion. Okay. How you want to proceed? So what are the possible DDs in this child with this clinical presentation?
Post-meningitis sequelae due to vasculitis problem.
Yes, as the post-meningitic sequelae and any other DDs? What post-meningitic sequelae could be possible here?
ADEM.
Anything else? Pyogenic. Hydrocephalus. Okay. Any other? Okay. So it could be your post-meningitis sequelae like brain abscess or infarct or hydrocephalus or CSVT, or it could be acute demyelinating cause. So what workup you want to do? So what workup you would like to do in this side?
Repeat MRI. MRA.
Anything else?
LP.
Definitely MRI. MRI we should do. Anything else?
LP.
CSF and CSF analysis, LP. Okay. Is there any contraindication here to do LP directly? Yes, we don't know whether there is raised ICP. Child is an altered sensorium. So I'd like to rule out raised ICP.
Sure.
I would like to go with imaging first, then LP. Anything else you want to do? So I'd like to send again CBC and CRP electrolytes I would like to send CBC, CRP and electrolytes and do imaging and then to decide about CSF analysis. So this is the MRI brain of the same child. So what are the findings you could see? Anyone?
Hyperintense is occipital lobe.
Yes. There are so many hyperintense lesions seen at the gray white junction near the vagina. So multiple hyperintensities are seen near in the white matter and gray white junctions and in the basal ganglia, indicating demyelinating pattern. This is the contrast MRI film. So MRI brain consists of multiple bilateral asymmetrical lesions in the brainstem, cerebral hemispheres, at the gray white junction, deep brain nuclei and pericallosal regions. So what is your impression after MRI brain?
ADM.
Definitely MRI is showing demyelinating pattern. Probably it is ADM. So we will see what briefly about ADEM, whether the child is fitting into the criteria or not, and how to manage this child. So ADM is an autoimmune condition. It is defined as defined as per International Pediatric Multiple Sclerosis Society. The diagnostic criteria include all these findings, and all are required to all should be present to confirm it as a case of ADM. It is described as first polyfocal clinical central nervous system event with presumed inflammatory demyelinating cause, and there should be abnormal MRI brain, and there should be encephalopathy. And the MRI findings should be hyperintense lesions which are diffuse, purely demarcated, involving predominantly cerebral white matter. So this child has all of the following. It has encephalopathy, and there are MRI like hyperintense MRI lesions, and there is a polyfocal presentation. Coming to the etiology of acute disseminated encephalomyelitis, it is also described as post-infectious encephalomyelitis. Most commonly, it is seen after infections, and the following organisms are implicated in acute disseminated encephalomyelitis. The most common bacteria implicated are Mycoplasma pneumoniae, Campylobacter, Chlamydia, Borrelia, Legionella, Leptospira. Common viruses include cytomegalovirus, virus, and others named
Ma'am, sorry to interrupt. Can weekly positive mob you can take as specific in an encephalitis child?
weekly positive. Hello.
Smog antibodies, ma'am. Weekly body screen. Can you take it as specific? Can we consider for treating that any encephalitis child?
Yes, if an embody is positive, it is confirmed that it is ADEM. and we'll discuss later about it.
Okay, ma'am. Thank you.
And viruses implicated are cytomegalovirus, Epstein-Barr virus, herpes simplex, hepatitis A, enterovirus, HIV, coronavirus, measles, mumps, rubella, coxsackie virus, and varicella zoster, and dengue. And parasites implicated are Toxoplasma, Plasmodium falciparum, Cryptococcus neoformans. Most commonly, it is post-infectious and it can be seen post-vaccination also. Coming to the pathogenesis, it is immune mediated and inflammatory process. So there is a genetic predisposition. Most of the patients with ADEM had increased frequency of HLA-DR1, and when genetically susceptible individuals are exposed to this infections or vaccination, there will be an immune dysregulation, and it can be described as molecular mimicry between the microbial epitopes and myelin proteins like myelin oligodendrocyte MOG and myelin based protein. And other mechanism described is neurotropic microorganisms where the blood-brain barrier is disrupted, and they release certain cytokines which could manifest the disease only in the CNS. And because of the molecular mimicry or neurotropic microorganisms, there will be an immune-mediated injury resulting in activation of both cell-mediated and antibody-mediated responses, cytokine storm, and increased vascular permeability and neuronal damage. And this will become a vicious cycle, resulting in neuronal damage and clinical manifestations. So myelin oligodendrocyte protein antibodies are confirmatory, and they are more commonly present in children. In ADM in children, we can more frequently isolate anti-MOG antibodies than in adults, and anti-MOG antibodies also indicates fulminant disease or relapses are common if anti-MOG antibodies are present. So in this child, we sent anti-MOG antibodies, which turned out to be negative. So coming to the management, first line treatment includes IV steroids, pulse dose of methylprednisolone, 10 to 30 mg per kg per day for 3 to 5 days. And we can taper with oral steroids over 6 weeks to prevent the relapse. And if first line management fails, we can try IVIG at 0.4 gram per kg per day for 5 days, or 1 gram per kg per day for 2 days, or plasmapheresis. And in literature, there are certain case reports that there is a response to cyclophosphamide or rituximab in cases of fulminant disease. So treatment algorithm includes, so in any child with ADEM, your supportive management like neuroprotective measures, treating infectious etiologies, if any and bacterial infection is present, starting antimicrobial drugs, controlling fever, and first line treatment includes your pulse dose of steroids. If there is no improvement to first line management, we should go to second line management, that is IVIG or plasmapheresis. And other supportive treatment should include physiotherapy and neurorehabilitation. So in this child, we started on injection methylprednisolone at a dose of 30 mg per kg. So after starting on IV methylprednisolone, the child's sensorium gradually improved and power of the upper limbs improved, but lower limb power initially improved and again started worsening. So child also developed a neurogenic bladder So in view of worsening power, child is given IVIG and continued on 1 mg per kg oral steroids after 5 days of IV methylprednisolone. So there is no response to IVIG and child is started on rituximab. Child showed improvement after 2 doses of rituximab, and now the child is able to walk. After 2 doses, he is able to walk with support, and now he is able to walk without support. So this is the case report where it is showing ADEM in a 17-year-old female child following salmonella infection, and there is response to rituximab. So after starting the child on rituximab, after first dose, they are able to extubate the child from ventilator, and by the end of fourth dose, child is totally normal. So these are another 2 case reports where there is response to rituximab. This is a case report in immunosuppressed individual after transplantation, and this is in like fulminant case where there is no response to any other IVIG or steroids, but there is response to rituximab. So to summarize, any child presenting with any acute systemic and neurological signs and symptoms, always take an accurate history and good clinical CNS examination. So if there is a suspect of acute CNS infection, go for LP and cultures and viral PCR and other microbiological studies. If it is positive, go for specific therapy. So in this child, during the first presentation, there are signs of CNS infection. There are meningeal signs. There is encephalitis. Sorry. And LP's CSF analysis suggestive of meningitis, and the etiology also we could rule out we could identify that is enteric encephalitis. So there is a response to specific therapy, that is IV antibiotics and steroids. The same child presenting after 4 days with signs and symptoms, but the history and physical examination is not suspected to be of CNS infection, and we should suspect demyelinating disease. So to rule out demyelinating disease, go for imaging first. Imaging findings are confirmatory, and we can also go for serum antibodies, that is anti-MOG antibodies and anti-aquaporin antibodies. So if MRI lesions, MRI is showing lesions, that is diffuse, purely demarcated lesions involving the white matter, which are hyperintense lesions. So it is ADEM, suspect ADEM. So what are the take-home messages? So here take-home messages are importance of neuroprotective measures in stabilizing the child, in preventing further clinical worsening. So either in the first scenario or in the second scenario, whenever child presented, at the end of your primary assessment, we don't know what is the exact etiology, but we could manage the child, like take control of ICP with the help of proper neuroprotective measures. And importance of CNS examination in narrowing down the diagnosis. So proper clinical examination will always help to narrow down the diagnosis and also help to cut down your unnecessary investigations. And whenever there is implicated, always go for imaging whenever child is stabilized. So if even if the child is on ventilator, you can go for imaging. If the child is hemodynamically stable and there are no ICP spikes, definitely go for imaging as early as possible. And whenever there is a doubtful etiology and infection is not clinching your diagnosis, consider demyelinating causes whenever there is a doubt. Any questions? Any questions to be answered? And we should not be in a hurry for LP. There is a question in the chat box. So whenever child sensorium is subnormal, or whenever there are unequal pupils, there are a clear-cut signs of raised ICP. So in that cases, we should avoid LP rather than going for diagnosis. Will unnecessarily harm the child. So rule out raised ICP first. Make sure that there are no signs of raised ICP or cerebral edema. Then only go for LP. Consider Japanese encephalitis in the case you have presented. Definitely in the first, during the first presentation, we could even suspect viral encephalitis. But the MRI brain is normal. And the child is not even from endemic area.
Hello, ma'am.
Hello.
Ma'am, if a child is having sepsis and is having ADEM lesions in MRI, ma'am, can we start steroid, ma'am?
Yes. We should take like proper cover of antibiotics for the infection and start steroids.
Thank you.
So any other questions you can post in the group. We'll be happy to answer. So I'm ending the session. Thank you. What is the, 1 second, there is another question in the chat box. What was the clinical condition during the treatment of pulse, MPS, IVIG and rituximab, whether the child was on ventilator or inotrope support? So this child is never required ventilator support, like his airway breathing is good. Even his GCS is never less than 10 and it always improved with treatment. Once we, and noradrenaline also we could wean off after starting on pulse dose of methylprednisolone by day 2. So this child, there is a definite clinical response in terms of improving sensorium, improving power after starting steroids, and even we could wean noradrenaline, and he's not on ventilator anytime. And as there is a again worsening of power and the child developed neurogenic bladder, and we considered IVIG, but there is no response to IVIG. So we tried rituximab. So there is an improvement response to rituximab. I'm closing the session. Thank you. Now,